All right, guys, we'll get going. Thank you, Chief Love, for having us out here today. We appreciate it. With Alabaster Fire at Shelby Baptist. This is the EMS Challenge. We'll be here from 9 to 10. I'm going to go over a couple of cases. And then Dr. Rose will talk about burn management. You don't want to miss that. If you're online, remember at 10:30, Jamie Gray is doing an update on some EMS issues with nursing homes. You may want to have somebody log into that and listen in as well. Maybe some good information. I'm not sure what the complete agenda is, but it should be pretty quick. But just FYI. Okay. All right, if I talk too fast, somebody stop me. I had too much caffeine. If I say anything too inappropriate, let me know too, okay? And we'll delete it out. So EMS Challenge was started back in 2014, 1st of 15, with the goal to improve patient care. You know, 20 years ago, when I was doing EMS, there seemed to be a lot of physicians involved in EMS. That seems to be waxing and waning now, not as many docs out there. So the goal of this is to bring physician-led Con Ed out to EMTs, to advanced EMTs, and to paramedics. So we're doing that through myself and the UAB Emergency Residency Program as well. In 2013, the group that credentials ER docs set up a new credentialing process, and it was to credential ER docs to go out and help with EMS again. So it's an additional year of training after college, med school, and residency. We plan to start one of those programs in July. We'll have 2 fellows. So this is going to be ER docs, practicing docs that are board certified, trained in emergency medicine. They'll be out in the BRIMS region doing EMS work with me, with the hopes of getting more and more as we go on in the future. You know, the things that we do in pre-hospital now are things we don't let the interns in the hospital do without an attending physician there. You know, you guys have a lot of responsibility. You're intubating, you're defibrillating, there's synchronized cardioversion. There are meds out there that some meds I can't even get. For example, ketamine. We use ketamine pre-hospital. There are some hospitals in this state, when I go to Moonlight and work, I can't get ketamine as an ER doc from a pharmacist, but yet you guys have that. So there's a lot of responsibility. There's a lot of training. If you went to paramedic school 10 years ago, a lot of things you learned there have changed. There's a lot of things that we're learning now with the internet, with science moving so fast, you got to keep up to date. So that's the goal of all this, okay? For your Con Ed certificate, you can email us at alabamaemschallenge@gmail.com. You can also scan, if you're here, you can scan the QR code, and then Chief Ward will put in the chat box a link to get this. We have both the nursing and EMS Con Ed, all right? Regional updates. Can y'all see the screen okay, or is it too bright for you? A little bright, that's what I'm thinking too. No clue where the light switch is though. Oh, sorry. All right, guys, squint. So protocol updates. Remember, TXA changed from 1 gram to 2 gram. It's category A now for traumatic hemorrhagic shock. We have our YouTube video up. You can watch that. And for EMS personnel, if you watch the YouTube video, take the test, you get Con Ed for that. National Registry has approved it. You can watch videos. You don't have to do everything online because of the pandemic. So that's out there for you. COVID is still here. Numbers in the community are rising. Hospital admissions are about the same as they were several months ago. But the point of that is remember to wear your mask. I know you hear enough of that stuff out there already, but COVID is still here. System entry stuff at TCC. Remember early entry for STEMI, stroke, and trauma. With a lot of hospitals boarding patients in the ER and the volumes increasing, you know, where are you going so you're not waiting in line to get somebody seen. If you need medical direction in the BRIMS region, reach out. I'm happy to help you. If you don't like me, you want to offend me, I'll find somebody that can help you, but you need an active medical director, okay? And then wall times. Before the pandemic hit, we're setting up a wall times committee to address some of the issues we had. Then COVID came and things got a lot worse as far as wall times. What I will ask is that everyone not be that picture. That goes for nursing staff, physician staff, and EMS. This all be nice. Remember, the goal of this is to keep people alive as long as we can, take care of people. So if you get to a hospital and they're running the code, and there's nobody take your patient, don't just drop them off and head out, okay? And also, if you get to a hospital and they're making you wait an hour for somebody to go to triage, let us know, let me know, and we'll address that as well. We have to be reasonable. You can't be waiting on the wall for 2 hours. Sometimes it takes more than 10 minutes to get a patient into a room and registered, but we got to work together, okay? Thank you for smiling, as nobody did. Good, I like that, very good. Educational opportunities in December, we'll be in Anniston. In January, we're gonna be at Foley. And February, probably be in the Brims region. If somebody wants to host us then, we'll be happy to do that. All right. So I want to talk about ketamine just for a few minutes. I had a couple of cases this weekend where some dosing issues came up. I just want to kind of refresh this. And, ketamine is one of those drugs that, again, it's tough for me to get as an ER physician sometimes. So the fact that the state approved it and the anesthesia that's used is a great thing, all right? The protocol reads for ketamine for altered mental status, but it's really more for what we call excited or agitated delirium. The 80-year-old nursing home patient that has a UTI that is spitting at you and clawing at you does not need ketamine, right? We should be able to manage that in a safe manner. The butt-naked guy that's chasing the police probably needs ketamine. That's what it's really used for, okay? Agitated delirium or excited delirium is kind of a catchphrase that we use, and it can be caused by people who have been doing meth or coke, okay? It can be somebody who's highly intoxicated. It could be someone who's a psych patient, been off their Haldol for several days, and now just completely manic. But again, it's not the elderly person who's a little bit confused. When you think about using ketamine for someone who's agitated, you got to think about, is this person a risk to their safety, to my safety, or to the public safety? All right. Dosing for ketamine. Anybody know what the dose for ketamine is for excited delirium in Alabama? So you got this butt naked guy that the cops have now shackled to the ground. Then you help him to the hospital. You want to give him some ketamine. How much do you give him? Yes, 4 mg per kilo IM, right? No. So state says you can do 4 mg per kilo IM, or you can do 1 mg per kilo IV. My thought is if you can put an IV in somebody, they're not kicking your butt. They probably don't need ketamine at that point in the game, okay? When you think about dosing ketamine, though, it's based on ideal body weight. And that's something we never learned back in paramedic school, and that's something we have a hard time teaching in the ERs as well. Ideal body weight is based upon height, not weight, okay? So if you got a guy that's 5'4" and 280, and a guy 5'4" and 100 pounds, they get the same dose of ketamine. And that's kind of contrary to what we believe sometimes, all right? Now, picture on the right, tall guy, short guy, 2 different doses. The guy on the left should be the same dose. There are a lot of formulas out there for ideal body weight. Most of them were made back when Chief Ward was in high school. This one was made in 64, then you got 72. Really haven't changed much of this, and they're kind of confusing. What I've done is I've kind of put it together in the way of my mind, and I think if someone's 5 foot tall, I said they're 52 kilograms, all right? And for every inch over 5 foot, they're 2 kilograms. So if I got a 6'4" guy, that's what, 16 inches plus 52, he's 68 kilos. That's the dose, that's the weight I would use to dose him with ketamine, all right? Now, this is rough. This is not exact science, all right? So if I know that I was 6'4" and the patient's taller than me, I know he's more than 6'4", and vice versa. If he's shorter, I know he's shorter. And that's how I calculate the dose. The reason being, ketamine is a relatively safe drug. So there have been case studies of kids getting over 500 milligrams of ketamine, which is way too much for anybody. And the only bad event was the kid quit breathing. It was on the ventilator for a couple of days, but no adverse event when you manage the airway, okay? But the adverse event you can have is airway management issues, folks. So if I got a guy 5 foot 6 inches, he's 350 pounds, he's a short, stout guy, that's 160 kilos. If I give him 4 mg per kilo of ketamine, we're talking 640 milligrams. So you pop it open 2 vials of ketamine, that should be a red flag, something's wrong, all right? If you're ever giving somebody 500 milligrams of ketamine, that's a red flag. If I was king for the day, I would say stop ketamine at 400 milligrams. That's the biggest IM dose you want to give, all right? If you use ideal body weight based upon his height, he's only 64 kilos, so he gets about 250 milligrams. So there's a big difference in dosage. And the difference in this means if he gets 640 milligrams and he gets to the ER, he's going to buy an ET tube, he's going to the ICU. His risk of aspiration goes up, his long-term risk in the ICU goes up, his hospital bill goes up, right? Versus a lower dose, which probably sedates him a little bit. The goal of ketamine is to chillax them so they don't kick your butt and hurt you on the way to the hospital, all right? Post-ketamine, so anybody that gets ketamine is no longer a psych patient, they're now a critical patient, all right? If you give ketamine, once they get chillaxed enough to safely evaluate them, you cut their clothes off, they get on the cardiac monitor, they get on the sat monitor. You're looking for holes, you're looking for patches, you're looking for track marks, anything that can kill them. You get a glucose on them, all right? If you have waveform capnography, do y'all have that out here, the nasal cannula stuff? No? Yeah, those are pretty expensive. If you have them, that's great, all right? And you can watch the respirations and the end-tidal CO2 to see if they're breathing well. If you don't, a sat probe is wonderful. The thing that bites people is they get this psych patient, they get the ketamine, now they're chillaxed, they cut their clothes off, they look at them, AccuCheck is 150, which is fine, and their sats start dropping down. Is that fire or medical? Fire, all right. Y'all be safe. If y'all get a medical, will y'all run out like you're really excited for me, please? So I know you're excited about EMS. Thank you. All right. So post-ketamine, you put him on the sat monitor and he drops his sats. His sat go down to 90%. The mistake people make is they put oxygen on this guy. Ketamine does not make you hypoxic. It makes you not breathe. If you don't breathe, you become hypoxic. So if you put oxygen on a dude that's breathing 4 times a minute, and you don't recognize he's breathing 4 times a minute, his sats go back up because of the oxygen, right? But his CO2 rises, and about 10 minutes down the road, he goes into cardiac arrest. So post-ketamine patients do not get oxygen. They get airway management. Dude gets ketamine, you expose him, give him a monitor, his sats drop. First thing you do is you jaw thrust. If that doesn't work, you put a nasal trumpet in him. If that doesn't work, you get out your ambu bag, hook it to O2, you get O2 and you ventilate the guy. If you just give oxygen, somebody's gonna die, and that's poor form. All right, I want to talk about scope of practice for the EMT. So we used to call EMT basic EMT, and there's nothing basic about it now. There are a lot of services throughout the nation that are relying on EMTs to do the majority of the medical care. So scope of practice for EMT has gone up a lot. There's a lot of things these guys can do. They can do blind insertion devices. They're actually supposed to start learning about capnography, AED use. Their medication list is going up. So very important stuff that we understand the basics. Some of the things that I learned in my basic EMT class, 30 years ago, I still use today, right? So airway management, jaw thrust, OPAs, those things. Even in the hospital now, when I go to intubate somebody, I have an oral airway in my pocket. Just in case I can't get them tubed, I can't ventilate, I got a way to manage that patient. So very important stuff. I'm gonna cover a few things on this today before we get to our cases. All right, so talks about EMTs got to do appropriate history on folks. People get caught up on trying to get too much information on the history. So I think about if you can get a history, past medical history or medication list on somebody, you want to do the STMs, the stuff that matters, right? I don't care if somebody's on vitamin B12, if they take supplements, things like that. I think about the things that I can use in my mind to risk stratify what's going on. So if I have a guy that's 50 years old having chest pain, the history things that matter to me are, what makes me think this is coronary and not something else. So my questions would be any history of hypertension or heart disease. He said, yeah, I've had a couple of heart attacks. And then my little red flags are flying in my brain saying, okay, 50-year-old guy had a heart attack in the past, now having chest pain. I need to move a little bit faster and figure out what's going on with this guy, okay? If he says he has a history of COPD, he has lung problems. It makes you think about need to get a SAT, need to listen to his lungs, all right? If he says I have no health problems, I'm an athlete, I run 14 miles a day, then you might start thinking something else, move a little bit slower, all right? But history should kind of guide you into your response to the patient complaint, all right? Questions, comments, statements within reason? All right, sweet. And then ABC is very important. Anybody know what this group is? I did this for Chief Ward as well. I'm not sure why I did this last night. That's ABBA. Yeah, nobody listens to ABBA except for Chief. All right. So it's kind of the ABs, all right? Airway and breathing. Breathing and airway kind of all runs together, right? So you don't do one without the other. We teach the residents and the doctors that when they see a patient, that they go in and get a history, they do a physical exam, and they come out and make a plan and go back and intervene on these patients. We don't do that. We don't have that time, right? So we need to get on scene, determine if they're sick or not sick, and get a plan and a history all done in a couple of minutes. So we do our A beat all together at the same time. You recognize that song, Chief? Okay, I thought you would. Yeah, all right, that was for you. More recent C's and then D's. So circulation. When you think about circulation, you always think about extremity perfusion. So if I show up on scene that's somebody that's altered and confused, I'm gonna get down, introduce myself, hands on the patient, checking the radial pulse. I'm looking at the respiratory pattern. Rate doesn't matter so much because nobody counts respiratory rates well, right? In the ER, everybody has a respirator rate of 12 and they're dead, then the nurses give them a 0. or they have COPD, and then they get like a 20, right? Work of breathing is much more important than rate of breathing. If I'm down talking to somebody, I'm looking at them, are they sitting upright, are they tripoding, are they using accessory muscles? If I'm counting for 15 seconds and I get more than 4 respirations in, I know they're breathing too fast. So rate doesn't matter at that point. Whether it's 24 or 40, I know they're dyspneic, all right? When you think about disability things, the things that make people altered, things you should always think about is things that we can fix quick early on. So an AccuCheck, a quick glucose, if it reads low, we know what the problem is, we can fix that, right? If it reads high, we know what the problem is. They're probably in diabetic ketoacidosis or hyperosmolar. We know how to manage that. If it reads anything between low and high, doesn't really matter. We just, yep, you're diabetic, but not a scary thing, okay? So we use that as a screening tool. I always think about strokes. When you look at the stroke data for our region, we got a great response in the stroke system. About a third of the patients put in the stroke system are having strokes. The other 2/3 do not, but about 80% of them go to the ICU. So we recognize sick or not sick, which is fantastic. All right, so airway management devices. So I remember learning about OPAs and nasal trumpets. Cool thing is we also have some blind insertion devices now. But remember, basic things help you a lot. So if you got a guy laying flat on the ground, he's 350 pounds, he's got sonorous respirations, he's not moving air much. You know, get behind him, sit him up, open his airway, slide a nasal trumpet in, see if that helps. If that doesn't help, great grammar. If that doesn't help, then you can think about, does he have a gag reflex? Can I slide an OPA in for this guy and move toward assisted ventilations? Basic things go a long way. Are y'all using Kings or iGels or AirTracks? What do y'all have out here? King. So there are a couple of devices on the market that all work relatively well. I'm an iGel fan. King is a reasonable device. It was Rock usually several years ago. A lot of folks went to them. Easy to use. They got a double balloon on these folks. And in theory, the way this works is you shove this gently in the mouth hole, you inflate the balloon, and the distal end of it there should be right above the cord so you can ventilate through them. Couple of issues with it. One, from a resuscitation standpoint, you got this big 30 ml balloon here. And so when that is inflated, if somebody's in cardiac arrest and you're trying to push blood with CPR to the brain, it kind of limits flow up and down. So there's some data that probably hinders our CPR efforts, okay? The other problem is it takes a little bit longer to insert these. Do y'all inflate the balloon, deflate before you put them in? No, yeah, we're supposed to do that. I don't either, sir, so you're fine. Yeah, so in theory, you're supposed to inflate the balloon, make sure it works, lubricate it, deflate the balloon, then shove it in the mouth hole and ventilate. In reality, a lot of times we just take things out of the package. I don't use KY jelly. Most folks that I got to put a King airway in, they have some vomit in their mouth or secretions, and I use that to kind of lubricate it, kind of rub it on the cheek and then slide that in and inflate the balloon. So fairly easy to use. From an ER physician side, when they get to the hospital, has anybody ever seen the ER doc cut the balloon and take the tube out to intubate them? You almost have great docs out here. Good, yeah. So I've seen folks come in by EMS intubated with this. The ER physician want to take that tube out to intubate them because that's what we do, right? And they cut the cuff, right? They pull the tube out, they go to intubate, they can't intubate them, and now there's no device to replace to manage that airway. So I'm not a big King fan. It does work. But I'm not a big King fan because of the balloon there. I'm not a big LMA. They got a cuff and a balloon too, right? Yeah. So the question on the internet world was King versus LMA. I don't like the stuff with the cuff because it's just one more step to do. Does it work? Yeah. Do they use them in the OR? Yeah, all the time. I'm not a big fan, but I'm not always right either. Let's see if this video will pull up. I'm guessing not. All right, so these are iGels. This is what I'm using now. I think these are relatively easy to use. They're doctor proof. You can't mess it up. So currently right now where I'm working in the ER, if we have a cardiac arrest come in with the COVID, we're going to slide one of these in first, continue CPR, get our gown on, our mask, get everything we need for safety before we intubate them. These things are pretty easy. They're eye gels. So they come in a package. Some of them have an adapter on the top part so you can hook up O2 and do passive O2 with those folks. So you can hook O2 on there, crank it up to 8 or 10 liters. So you're getting great passive oxygenation, all right? You can also ventilate with an ambu bag. But these things, manufacturer says lubricate with some KY jelly. You pull the jaw down and forward and just slide this thing in. You get resistance twice. So when it goes into the mouth hole, you get resistance. When it reaches the back of the oropharynx, a little bit of resistance, you push a little bit farther, and it seats right there at that glottic opening. The gel that does the cuff there is heat sensitive. So when it gets to a warm body, it kind of suctions to the glottic opening, and you get pretty good seal. So these, I see a lot better end-tidal capnography when you're using this during CPR or even not during CPR. You get great exhalation. Still, when you ventilate, you have the bag on here and you squeeze, it will kind of push away a little bit and you still get some air in the belly, but it's a great device. It's super simple. So we good? Oh, okay. Thank you. You leave it on. Yeah. All right. So these can be used by med students, by ER docs. I mean, super easy, minimal training. The only side effects I've seen or issues with this is occasionally you see somebody put it in too low and it gets stuck on the tongue and then it won't go in. So if it doesn't go, don't force it, right? The other issue I've seen is I've seen a tongue ring kind of tear up and scratch up this little end piece as well. But for the most part, this is pretty easy to use. So as an EMT, you can use this in the state of Alabama now. So if I was king for the day, I would take OPAs away and just use this. All right, I think we're coming to that in the next 10 years. Very easy to use. They size them down all the way to kid sizes as well, so super easy. I brought some today. We're doing the skills labs you can look at, and I don't sell them, so I'm not trying to sell you a device. I'm just saying this is really user friendly. Okay, it's almost idiot proof. Doubt this video is going to work either. Oh, the EMTs out here, y'all using the Kings yet? Have y'all been checked off? Y'all using those? Or is it more the medics doing the Kings? Or no comment? No comment. Good. I like to talk to my kids. This is great. Thank you for interacting. Yeah, that's right. Yeah, I brought gifts, but none for you if you don't talk.
We did continuing education for the EMTs to do capnography.
Okay.
Blind insertion.
And blind insertion? Okay. Yeah. So I recommend if you guys have not used them that you at least practice on these things. The Kings need a little bit more training. The eye gels are really idiot proof, but you still need to train on those before you get out and do that. And then capnography, again, for the EMT has been approved by the state and it's part of the national core curriculum as well. Now, it's not super fancy. We're not looking to see do they have COPD, CHF. We're looking that once they place that eye gel or King in, they put waveform capnography on, and do you see ventilation? Are you in the right hole? You should confirm your blind insertion device with capnography just like you do an ET tube, okay? You can always use your SAT probes. Remember, SAT probes run about a minute behind, but any kind of tube placement, whether it be ET tube, blind insertion device, you got to use capnography, okay? All right, questions within reason? Sweet. Let's talk about I got a case. This was a 73-year-old male with abdominal pain in a nursing home. So how do we manage those folks? You show up on scene. We already talked about we can get our ABCs by getting a history. So I'm going to show up. I'm going to do an across the room assessment. What's the guy look like? You know, is he awake? Is he alert? Is he breathing fast from across the room? Does he look pale? Does he look chronically ill? Does he look like his stated age? Does he look like a 70-year-old male? Or does he look like he's 120, right? So you can pick up kind of what's going on just across the room, all right? My hand's on his pulse. Is he warm or is he dry, all right? Is my partner's getting hooked up to the monitor, thinking about getting an AccuCheck and getting IV access started on him. So he's a little bit tacky, skin's warm and dry. He says he got a history of COPD, hypertension, and diabetes. Sorry. Maybe he has a history of AFib as well. You can start asking about his medications. He takes a blue pill, a white pill, and a round pill. You ever get that? I love it. It's like they get these all colored pills. Doesn't help you a bit, right? So what history matters on this guy, and what other history can you suspect? So he's 73, so you suspect he has a lot of health problems. You also suspect that he doesn't have much reserve. By that, I mean, if he was septic, if he was infected, if he was dehydrated, those guys go from looking really good to dying on you, almost like kids do. So remember, he's a geriatric and pediatrics kind of go from looking good to crumping pretty quick. All right. When you think about his history, COPD, we said he's breathing a little bit fast. That gives you an idea of underlying respiratory problems. COPD leads to right-sided heart failure. So you think long-term COPD, he probably has heart disease as well. When you think about AFib, that tells you that he was smoking forever because now he has some heart issues. And then also what goes on with AFib, what medicines do you take with AFib? Anybody know? Blood thinners, right. So folks with AFibs are on blood thinners. So they're high risk for bleeding out, having issues like that. If they fall, they're high risk for head injuries, bleeding in the belly, bleeding in the head. So kind of risk stratifies, gives you an idea that the guy could be pretty sick, okay? When you think about abdominal pain, you think about the textbooks talk about you got these 4 quadrants, things that can go on there. Older people have a blunted response to pain. So they may say abdominal pain and can't localize it. So it's kind of hard to go. But in theory, right-sided, right upper abdominal pain, you think liver problems, hepatitis, liver disease, you think gallbladder problems, all right? You also think kidney problems. The kidney sits real high and wide there. Left upper-sided abdominal pain, you think about colon issues. I used to think more about pancreatitis, issues like that, left upper quadrant. Right lower quadrant, what do you think about? Appendicitis, yeah, that's like Clackett's textbook, right? Think about appendicitis. Appendicitis in a 73-year-old is probably pretty rare, but you think about it, right? And then left-sided abdominal pain in a male, you always think about diverticulitis, especially older folks. You think about diverticulitis, we'll talk about, okay? So we kind of talked about what COPD makes you think about. Smoking also is a big risk factor for a AAA, acute abdominal aneurysm. So folks who smoke are at a higher risk for getting a large vessel in their belly. And those folks can have, as they get older, those things can leak, cause abdominal pain. And if they rupture, it's just like somebody being shot in the belly, bleed out pretty quick. So older guy, smoking on blood thinners, big risk for an aneurysm, okay? The other thing I would say is when you think about abdominal pain in people that are 50 plus, I always think about referred pain from the diaphragm, like pneumonia or heart disease. So I can't tell you how many folks have come in having abdominal pain, nausea, and vomiting. We get an EKG, and the EKG is all jacked up, having a big coronary event, because abdominal pain here can also be coming from the heart as well.
Hey, Doc.
Yes, sir.
Hey, press the button under battery pack, please. Turn the mic off somehow.
Sorry. We back on? Sorry about that. So, got hands on this guy. I'm checking a quick radial pulse. He's a little bit diaphoretic, breathing a little bit fast. I'm gonna sit him up. We're getting a set of vital signs. Somebody's already starting an IV, getting an AccuCheck. Remember, it gives you a lot of information. And then I'm gonna reach over, lay my hands on his belly. And what I'm looking for is to see, is his belly pretty tender? So abdominal pain with a soft belly is concerning, but not super scary right off the bat, right? Abdominal pain, and then you touch his belly and it's nice and firm, and he calls your mama a name when he touches belly. That's concerning that he's got peritonitis. We got some kind of either perforated viscous, big infection, or that aneurysm have ruptured. Something's not right with that guy. So hands over his belly, quick, gentle push, all right? Other questions I think to ask these folks is surgical history. Anybody that's ever had surgery on the abdomen is at high risk for small bowel obstruction. The older you get, that risk goes up. Most of those obstructions can be managed non-surgically, but some folks get a bowel obstruction, that bowel twists and turns, it blocks the blood supply to it, and they can get really sick and die from that. All right. We already talked about nausea and vomiting. I always think acute coronary syndrome and somebody that's mature with nausea and vomiting or diaphoresis, get a quick 12 lead, right? Gives you a lot of data. If it says STEMI, you're not gonna be on a wall anywhere, right? You're going straight back. There's no waiting at the hospital. All right. Questions, comments, statements? And then the last question I usually ask folks who have abdominal pain is, have you had any rectal bleeding? Okay, any bright red blood per rectum? All right, changes everything. Remember, old guy on blood thinners, old guy, left-sided abdominal pain, you think diverticulitis, okay? Those guys can have some bright red blood per rectum, and that is a surgical emergency. Those folks can die pretty quick on you, GI bleeds. All right, everybody talks about hemorrhoids when you talk about rectal bleeding. Yes, you can get rectal bleeding from hemorrhoids, but that does not make you get hypotensive, doesn't make you look sick. You're not ill from that. You don't appreciate them, right? All right, so whether it's hemorrhoids or hemorrhoids, doesn't matter. Don't care. I don't even ask that question. All right, so we got a 73-year-old male, abdominal pain, left-sided. We got a quick assessment on this guy in a matter of 2 or 3 minutes. I got the appropriate history done. I've got IV access. I'm getting the glucose. He's alert. He's pale. Heart rate is 98. Blood pressure is 88/62. He's breathing 26 times a minute. Again, rate doesn't matter over about 18 or 20, but he's working hard. He's sat 91%, and glucose is fine. All right. So this guy's sick or not sick? I would say he's sick. He's a 70-year-old guy with a blood pressure of 80, right? Yeah, very concerning. He's a little bit tacky. Heart rate's 98. The problem is that we get so used in the ER and EMS that heart rates less than 120 or so don't really concern us, right? Everybody's a little bit tacky, all right? You show up in a big yellow truck, lights and sirens, everybody's nervous, they get tachycardic, right? Problem is, this guy should be more tacky. So why is he not tachycardic, probably? Anybody know? Yeah, he's got hypertension, so he's on some kind of medicine to lower his blood pressure. Those blood pressure medicines will slow your heart rate down, right? So his body cannot respond to his low blood pressure and mount a big heart rate. So don't be bit thinking his heart rate's fine, because older folks on all these hypertension medicines, it would get you. He's also breathing fast and hypoxic, so I would say he's a pretty ill dude. When you think about GI bleeds, we think about there's upper GI bleeds, lower GI bleeds, and most of them are non-specific. You can't tell if it's upper or lower. So things that can help you kind of determine it. Bright red blood out the butt is usually a lower GI bleed, something from the colon. So old guy, left side of belly pain, blood pouring out his butt, it's bright red, that's a lower GI bleed, okay? So we talk about things you can look for. If they're vomiting, this coffee ground stuff, everybody had that test on their registry a long time ago. That's digested blood from the upper GI when you throw it up. All right, melena is basically black tarry stools, and that's where you have a GI bleed, like an ulcer or something, or esophageal varices. They bleed the stomach, it goes through the whole GI tract, you absorb it, digest it, it comes out black. Bright red blood out the backside is usually diverticulitis or some kind of trauma to the colon itself. Pretty scary, okay? So bleeding in the gut is concerning because we can't pack it with combat gauze, all right? We can't do direct pressure, can't do things like that to control the bleeding. So you have no idea how much they're bleeding. They can bleed out 1 liter in their belly and not crap it out yet, okay? So these folks can get sick on you pretty quick. What diverticulitis is basically the colon. The older you get these little out pockets that kind of stretch through the colon wall. And occasionally those little out pockets you can see here, as those things erode away, they cross a blood vessel, and that blood vessel starts to bleed. If you're young and healthy and you have this, the body sends cells over, they stop the bleeding, not a big deal. If you're old and have a limited reserve and you have AFib and on blood thinners, you start bleeding, there's no way for that bleeding to stop. So people can die from this pretty quick. So bright red blood per rectum is a very concerning sign for these folks. All right, so a lot of red flags in this dude. He's an older guy, we got bright red blood per rectum, blood pressure is soft, heart rate's a little bit low for what you expect for a guy with a blood pressure of 80. Got a history of AFib, so even if he doesn't tell you he's on blood thinners, you assume he is, all right? He's tachypnic, and he's tachypnic either because he has COPD and he has the underlying lung problems, or he's acidotic because he's so sick from his GI bleed, he's breathing fast. Either way, he is ill, all right? So how do we manage this guy? So we first got to recognize they're sick. So we recognize he's sick. We've done our 2 or 3 minute assessment. We've got our vitals, we've got our EKG, we have IV access, we got our AccuCheck, and we're looking at the dude, so we know that he does not need to stay at the nursing home. We need to get up and start moving. So we're not gonna spend a lot of time on scene with this guy. This is like a trauma patient, okay? He gets up, you start moving toward the hospital. Expedite transport. There's also a new drug out there called TXA that we can use now, category A, for traumatic hemorrhagic shock. TXA is a great drug. It is category B in every case in our state except for trauma and hemorrhagic shock. But this guy can use TXA. So what TXA does, when you think about the body, when the body makes a clot, so we got that diverticulum, that erosion in the colon, it went through a vessel, dude squirting blood out of it. The body sends red cells, white cells, platelets to that clot, to that vessel. It tries to clot it off, all right? And then a few minutes later, the body sends more cells by there to see if they can break that clot down and the body won't bleed anymore, all right? So it breaks the clot down just a little bit. If it starts bleeding again, it rebuilds that clot. What TXA does is it makes it where the body does not break that clot down a little bit to check the stability of that vessel. So in short, it keeps you from rebleeding. So TXA is a great drug. There's limited risk to TXA. You can get a little hypotension from it, but most of the time, folks that need TXA are already hypotensive. So risk to benefit, they get TXA, all right? People who have coronary stents, like a stent in their artery from a heart attack, or if they have bad vessels in the femoral artery and they get a stent in there, if you give them some drugs in the hospital to reverse anticoagulation, those things can clot off and they can have a bad outcome. TXA does not make new clots, it just prevents your body from breaking down old clots. So the point of that is, this patient at that nursing home, you recognize he's sick, you got your IV access, you're gonna pick up, start moving to the hospital, all right? Somebody, the EMT, the medic, needs to be on the phone with med control. Hey doc, I got a 73-year-old male, he's got bright red blood coming out of his butt, he's hypotensive and tachycardic. I think he's on blood thinners, I need to give some TXA. Any reasonable physician would say, yeah, give him the TXA, all right? If they don't, let me know, all right? Sweet. Does this guy need IV fluids? Yes, no, or maybe? Yes. Who said, I got one yes, everybody else says maybe? I'd give him a little bit of fluids as well, right? I'm not gonna give him 3 liters, but he is volume down, all right? He's a little bit tachycardic for, he's not tachycardic, but a little bit hypotensive. So yes, I would give him a little bit of fluid, 500 or a liter. I wouldn't do much more than that. I'm giving that as I get my TXA, all right? And then he needs rapid transport to the hospital, all right? Have y'all seen rectal bleeds, GI bleeds before? Yeah, those folks would decompensate pretty quick. Usually it's pretty easy to pick up just because of the smell itself. So you got bright red blood mixed with feces, not an attractive smell. So at the hospital, things we're gonna do for this guy, we're gonna do a couple things. I'm gonna take a report from you at that point, recognize that you gave the guy some fluids and TXA. You're gonna talk about his history so that I recognize that he's probably on blood thinners. If I'm able to pull up records from this guy and see if he's on a blood thinner at the hospital, then I can kind of reverse that blood thinner. If I never seen the guy, so say I'm working in hospital A gets this patient, he normally goes to hospital B, I don't have records, doesn't matter. He's got AFib, he's bleeding out his backside, he's symptomatic, I'm gonna give you medicines to reverse this. So there's something out there called PCC, and it's a synthetic drug that we can give people, and if they're on Eliquis or Xarelto or Coumadin, it reverses that. So they would no longer be a free bleeder at that point in the game. It's pretty expensive stuff. It's about $25,000, $50,000 to give somebody a dose. All right, so pretty expensive, but it will stop that bleed and keep them alive. Because obviously we can't go in and do direct pressure just like you guys. If they're on Coumadin, we give them vitamin K. Vitamin K reverses Coumadin, a blood thinner. We give that IV now, so it's rapid onset. All right. We used to talk about doing colonoscopies on those folks. So we had the GI doctor come in, they put a scope up the backside, they look for the bleeder and try and tie it off. In reality, that's pretty tough to do. You put a scope in somebody's bloody backside, all you see is blood. So it's hard to find that bleeder. Doesn't really work that well. So the other option we used to have was surgery. He's bleeding out his backside, he's sick as dirt. He goes to the OR, we take part of his colon out, tie that off, he stops bleeding. That's a pretty significant surgery, especially in a 73-year-old. So now we got some cooler stuff we can do. We can do a CAT scan with an angiogram. So basically we squirt dye in their IV and that then get a CAT scan, and we can look in the belly and see which vessel is bleeding. And then the radiologist can go in with a catheter and kind of burn off that vessel. It's called embolization. And that's a lifesaver right there. Okay, so most places can do it Monday through Friday, 8 to 5. Some places can do it after hours as well. In the near future, I think we'll be able to do this 24/7 most places, but it's a good way to save lives. Okay, obviously things I do before I even consider calling a GI specialist or a surgeon or getting the CTA is I got to resuscitate the dude. So he's getting blood products and he gets FFP, fresh frozen plasma. That replaces the clotting factors, restores volume, and we keep doing that. There's some folks that have GI bleeds. I had one last weekend. He got like 6 units of blood for a plate that's 2 grams of TXA before he even stabilized. You just don't know how bad they're bleeding because you can't see the source. But these folks are super, super sick. Questions, comments, statements within reason.
Hey, Doc.
Yes, sir.
So I think a lot of times we see GI bleeds in the pre-hospital setting, and we don't really think it's that serious of a call. So
Right.
Give us an idea of what mortality's like for a typical lower GI bleed.
So somebody who's older and anticoagulated, I say it's probably closer to 20%. I don't have the numbers in front of me, but it's pretty significant. All right. Think about somebody having an injury, amputation of the arm, blood loss, and we don't put a tourniquet on it. What happens to them? They die, right? Same thing. Dude's bleeding from a vessel in his gut, and we can't tourniquet off. We can't stop it. So it's pretty significant. The problem is we all get dulled because we see so many patients that say, I threw up 3 times and there was blood in there. Anybody ever heard that? Yeah. So when you vomit, you got mucosa in your esophagus. That would kind of get stretched and torn a little bit. Everybody bleeds a little bit when they vomit. So that's not a super scary thing, okay? But bright red blood out the backside is super scary. Those folks are sick. They can die fast, very fast. So you got to recognize it, get them to the hospital. They need TXA. If you're working at an agency that is advanced practice in the state and you have blood products and FFP, they get blood products and FFP, okay? There are 5 ground units in the state of Alabama now that carry that stuff. So a couple of fire departments, there's 1 private ambulance service, 1 county one. So those things are coming to everyone in the near future. I want to talk a little bit GI stuff, talk about some PEG tubes. You may see patients at nursing homes that have tubes in their belly that we use for feeding, just so you know what those things are. There are 2 types. There's a PEG tube, percutaneous gastrostomy tube, and a J tube, which goes down to the small intestine genostomy tube. Basically, we do this for people who may have had a stroke, they can't swallow well, or somebody who's chronically ill and needs extra nutrition. Maybe they have had surgery on the belly, don't have a lot of the colon, so we want to give them more nutritional intake. So we basically make an incision. This is done in the OR, obviously. Tube goes through the belly into the stomach, and most of them are held on by a balloon or a mushroom catheter, and then you get feedings through there. So we get a lot of folks that come to the ER that the tube has come out. And the question then is that important or not important? And it depends. If that tube is less than a couple of months old, so if they had that tube put in 2 weeks ago at the nursing home, and they call you guys, take them to the hospital, and it's been just 2 weeks, there's a big risk that track is going to close up pretty quick. If that track closes up, they got to go back to the operating room, be admitted to the hospital, and get a new tube put in. So those folks should get to the hospital really quick so we can put a tube back in there before it closes up. If that tube has been in there since 1974, you probably got all day. It's not going to close up. That track is permanent. It's not going to change. So fresh tubes, 6-8 weeks, need to get to the hospital quickly so we can put a catheter in there. I've worked in some communities where the EMS brings the guy from the nursing home for PEG tube coming out. He rolls by, I stop, I put a Foley catheter in that tube. It works, and we smile and they take him back. And y'all don't like that, but it's fixed, right? Sweet. But the different types of tubes, they look all kind of a little bit different. Some have balloons, some just have the rubber caps on the end. I put a Foley catheter in somebody the other day for the same thing. It's just something to get food through there. The J tube's a little bit different. So the gastric tube or PEG tube goes to the stomach. So you put the food in there, fills up here. If they've had a stroke in the past and they can't swallow well, there's a risk they can vomit and aspirate. So some people will put that tube way down in the colon, or excuse me, the small intestine. That way, if we put too much food in there, it backs up and stops at the stomach and they can't aspirate it. So one question from a nursing home, if you're transporting somebody, is ask, is the tube a G for stomach or gastric, or a J? That gives me a lot of information at the hospital and it's pretty useful. And y'all, I'm not sure if this video is going to work. Oh, it is. How did that happen? Well, maybe not. All right, maybe we'll show it at skills lab. This is a inhalation injury from a house fire, and I wanted to show you. You can kind of see online, y'all can see it. You guys probably can't see it with the light. A lot of carbonaceous sputum. We'll pull it up for you guys at the skill station though in a little while. I'm not supposed to show EKGs except on the first Wednesday of the month, so Chief Ward's going to cuss me. But I wanted to show this. This is a great save. This was actually done by RPS. I forgot the date, but it was a 40, 50-ish-year-old male, nausea, chest pain. EKG here, machine reads, nothing serious, no STEMI. The medic was pretty astute. He kind of looked at this, looked injury patterns at leads 1, AVL, 5 and 6. Look reasonable, 2, 3, and AVF. We got this big ST depression. It's not a STEMI, but it makes you think there's some kind of ischemia going on. V1 through V4, we got this. It's called hyperacute T waves. It's not a STEMI, but it should make you think, okay, they're either hyperkalemic or something bad in the heart's going on. Yo. That's not where you touch it. I'm just gonna touch it. Hey, there's no laughing at me. That's not fair. And then that's V1 through V4 for septal or anterior. And then I look at AVR. So in 2013, American Heart made, if you're elevated in AVR and depression anywhere else, this is a STEMI equivalent. That means you should probably talk to our heart doc to make sure they're going to be okay. So medic calls TCC. TCC says, does the EKG say STEMI? That's the first question they ask you, right? We put them in the system. He said no, but I need to talk to the hospital about hospital entry. So if you have an EKG that's abnormal, talk to TCC. Tell them it doesn't say STEMI, but you want to talk to the closest available cath lab facility. Talk to the doc, send this EKG, then look at it with you. Okay. So this dude is up in AVR, up a little bit here, and depression. Big concern. He gets to the hospital. We're even more up in AVR, more up in V1. Still have this. This is a big STEMI. That medic caught it in the field 20 minutes prior to arrival. We're able to activate the cath lab. So guy, instead of spending 30 minutes in the ER waiting for the interventional attending, he goes to the cath lab in a couple of minutes. Great save by the medic, just by understanding, knowing these 12-lead EKGs. All right, great save. This is the dude's cath. So this is them putting a wire in the heart, the squirt contrast, and look, this is a proximal left main, completely blackened, completely whited out. And you look over here after the stent, great perfusion. Time is muscle. If this guy had spent much more time without having perfusion, the whole left side of his heart would have gone out. And the difference with that is, probably he may have still lived, but the difference is if he worked outside deconstruction, if he was a firefighter and he lost the left side of his heart, he is no longer doing his job. And now he can. So the work you guys do is very important. It's very corny for me to say, but you make a difference. You don't have to be a paramedic, okay? I know a lot of folks here aren't, or some aren't, but if you're gonna be a paramedic, you gotta understand the things that kill people. You gotta be able to recognize it, sick or not sick, know the appropriate pre-hospital interventions, and know where to go, okay? If somebody came to the hospital right now and they had a big head bleed, a subdural hematoma, I can't fix it. If I do surgery on you, you're gonna die, right? I'm not gonna fix you. But I should be able to recognize that patient, recognize what's going on, and get them to the appropriate place, okay? Just like you guys. Questions, comments, statements within reason, and if not, we'll take 5 minutes. And then Dr. Rose will be started back in a few minutes, folks. And I guess that's it for now.
Okay, we're going to take a few minutes breaks. Everybody, please stay tuned, and we'll be right back with Dr. Rose. All right, everybody, welcome back. We're pleased to have Dr. Amie Rose back with us today, and she's going to talk to us a little bit today about burns. So take it away, Dr. Rose.
All right, so hello everybody. I mean, you can hear me talking, I speak very different, very weird. So just a bit of background information. Born and raised in England, came over, immediately joined the military because that was like the most American thing I could think of. So I was a medic in the Air Force and then ran rescue up in Virginia. So now I'm here. So I'm going to talk to you a little bit about some burns today. Just kind of as a disclosure, I'm not getting paid for this, right, Ferg? Not getting paid, this is volunteer. Okay, anyway. So I'm not getting paid by anyone for it. And also I work for UAB, so a lot of my perspective is coming from this is how we do things at UAB. Obviously, if you go to different facilities, they're gonna, kind of handle things a little bit differently, but this is just kind of how we do it. So just talking about burns, as a forewarning, there's gonna be some images in there. I feel like you guys have probably saw some gnarly stuff, so should be okay with it, but I don't know, in case you're queasy. The big things that I'm going to do today is just kind of talk about the different types of burns that we see. So we've got radiation, chemical, electrical, and thermal. How to kind of like approach it, things to kind of consider, just little tidbits, and then what to do. So the one I'm not going to talk about is radiation because it's so low yield. But then tomorrow probably an atomic bomb is going to drop, and I'm going to wish I'd talked about it. But we'll start with chemical and just go to electrical and thermal and, call it a day. So, all right, so chemical. The biggest thing that we want to know when you guys are transporting is obviously what was the chemical, right? So there's two different big categories. I kind of break them down a little bit more for simplistically, it's acids and bases. Acids kind of tend to cause a coagulative necrosis. So what that does is it kind of does pretty superficial damage. The problem is when you start to get into your bases, it causes liquefactive. So it messes with like the fats in the body. And it can, you, just by looking at a splash burn, you're not going to be able to tell the difference. It's really on like what it actually is. But the problem is that the bases can actually cause like deeper damage. So the liquefactive necrosis is generally more deep, and then acids are more superficial. Liquefactive comes with its own like metabolic stuff. You guys don't really need to worry about that up front. But obviously always, one of the things that I always caution people on is when you get to a fire, you know that there's a fire coming, right? You know that there's going to be the potential for inhalation injury. You don't really know that if you've got like a chemical exposure. If you're going to a factory, you don't know kind of what's in the air. You can't see it as well. So just be cautious when you're going in there, like wear your respirator if you smell anything. If people are coming out actively vomiting, then, that's a big red flag. So then always your ABCs. So after you've done like your primary assessment, one of the things that I think is helpful is just like taking a quick assessment of what the actual like chemical is itself, right? That's like a big thing. So just looking at what the name of it is, how much were they exposed to? Was it just like a little splash, or were they like submerged, or, kind of how long it was on the body? Did they immediately rinse it off, or did it sit for a bit? Were they trapped in, like with their hands stuck? And then where it is as well. So is it something that they ingested? Do they have chemical burns in the mouth? Is it on the hands? Kind of, those are the things to really think about. This is like massive. If you guys could do this for us, it would be such a huge help. So when somebody comes in, they're like, oh yeah, it was my pool chemicals, or, occupational, hazard. If you have access to the MSDS, or if you can have like one of the employees just run and grab it, or just take a quick picture of the like bottle so that we know like what we're dealing with. Most of the time we're going to immediately go and Google it, but it's nice to at least know the name. Just so that we know if we're dealing with like an acid versus a base and how serious, it's potentially going to be. So that would be super helpful. So the biggest thing is kind of removing the exposure, right? So taking off any clothing that's saturated in any liquids, doing really bad, like good irrigation. So we actually have these things here called a Morgan lens. I don't think you guys carry them, but it's pretty gnarly to see. You just kind of put them in the eyes and rinse them out, and we'll hang like these hook up to like a liter saline bag, or whatever you have, and we'll just run it out and it'll just like drip out of both eyes. But if you guys could just like even rinse, like get a liter bag and just kind of pop it and just like squeeze it, and do it in a safe way. Obviously you don't want to be irrigating in the back of your unit while you're transporting. But that can also kind of reduce the amount that the skin is exposed and the damage later on. So, and then obviously transporting, and I think that that's probably just the big things, is just finding out what the heck they were exposed to and then irrigating as much as you can and keeping yourself and everybody safe. So that's pretty much it on that. Electrical burn, so we'll talk a little bit about that. So we see quite a few electrical burns. Most of it is actually farmers. We had a pretty bad one that just came to UAB probably 2 weeks ago. It was a guy on a farmer and he had, I don't know, something cutting down some trees and accidentally hit a power line, and he came in essentially charred from his head down to his toes. We tend to see like a trimodal distribution. So the big thing is the little kids going, you know, with the household sockets, usually 120 volts, low, and anything less than 600 volts is usually low, and then high voltage is anything above. Teen boys, I see a lot of boys in the room. So, you know, back in the day when you're doing crazy stuff and acting, yeah, everybody's looking around like, not me, I was good back in the day. And then adults with occupational exposure. So those folks that are working on like power lines, again, the farmers we see a lot of down here. And then there's a small like little subset, which is lightning strike. So only 25 to 50 people die annually from it, but when they get hit, they get hit. So just some basics. So, you know, you've got your little electrons, they move along, it causes, you know, power. The biggest thing that we want to know is, what was the exposure? Like, do we have kind of a guesstimate of how many volts they were exposed to? Was it like a quick exposure, or was it like they grabbed onto something and they were like gripped onto it and they weren't able to let go? And it's kind of the same as the chemical, it's just like a different source. Again, we classify it as like, was this low voltage or high voltage? But it also depends on how long they were exposed to it, which is the whole point of this slide. Is we have AC and DC. So DC, you know, is just one. That's like the cool one that you see in the movies where they touch it and they float, you know, fly back. AC is a little bit more dangerous just because you're grabbing on it, and because the alternating current, they have a hard time letting go. So you end up getting stuck on it a lot. But even with low voltage, if you look down on the bottom, that can still lead to cardiac arrest from VFib. So it's not a benign in itself. If like the kid is walking around, I don't know why anyone would let a kid walk around with a fork, putting it in like power sockets, but I'm sure somebody has at some point. If they're just like stuck in there, you know, obviously things to consider versus somebody who just has like an open exposure and like touched it and got a little jolt. So always, you know, as a scene safe for my safe, you don't want to be walking in a building that's flooded and you see sparks and stuff. That was like, oh, let's stage for a bit. So the big thing for electrical burns is just kind of stripping them down and having a look at the skin, because sometimes they might have a burnt hand, but you don't really know like how much that current has traveled, and body habitus can really play a big part in that. So one thing to look out for is look at the bottom of the feet. Sometimes people can have exit wounds that you wouldn't even notice, especially if they've got shoes on. So if they're at work and they accidentally touch something, or, you know, they for whatever reason their hand gets jolted, that current can travel right through the body and exit out the foot. So it's, if it's isolated to just like a hand, that's more reassuring to me than if I see that hand and then I also see the foot, because I know that that's traversed through that whole body to, you know, get to that exit. If you have the ability, just grab a quick 12 lead, just because there's such a high risk of like an abnormal rhythm, which can just range from like an AV block, like a full heart block, to like a bundle block, to QT issues, to AFib. Usually when you start having like somebody in VTAC and VFib, you'll know it when you get there. The evidence has shown that like later on down the line, the chance of them going into an abnormal rhythm at that point is so low, we don't even screen for it. So we just usually get an initial 12 lead unless they start having symptoms. And then electrical burns. So a standard taser is around 50,000 volts. The lightning strike itself is within the millions. So if somebody survives a lightning strike, that's pretty impressive. They can get these Lichtenberg marks, which is that cool little lightning. scar. Some people keep them, but most people it goes away, which really sucks because it would be really cool to keep that, right? One of the things we do worry about with lightning strikes, though, is the eyes and the ears. A lot of the times they can have some TM ruptures. That's not usually a big deal. We'll just cover them with maybe an antibiotic and just give them like some NSAIDs and it should heal on its own. They do need like an urgent ophthalmology consult though, because a lot of them get retinal detachments like immediately and then later on down the line can develop cataract. So just something to worry, to think in the back of your mind, like if they're having any vision issues, that they could have the potential for a retinal issue. And another thing with electrical burns as well is a lot of the time there's trauma associated with it. You know, if they're like hit and flown back, if they fall or flung into something, they can get things as minor as a dislocation, they can get broken bones. So always treat like an electrical burn as if it's a trauma patient. So you'll do your ABC, but then like after you've done your skin assessment, just give them a once over, just to make sure that there isn't anything obvious. Check pulses if there's dislocations, just to make sure they're not having any kind of neurovascular compromise. And then this is just like a general algorithm, but the whole point of this is I'm not going to go through it, but it's pretty much just showing that low voltage, so anything less than 600 volts. If they look great, we're discharging them. We'll, you know, check a basic EKG, watch them for a few hours. If they feel fine, they haven't had any symptoms, we'll send them home. Usually anything greater than 600, we're admitting them just for observation. Even if they look great, we'll just bring them in at least for 24 hours just to make sure that, you know, nothing happens. We do get concerned with rhabdo in these electrical patients. So a lot of the times we'll throw on a CK and just check a urine because the muscles can break down after you've got a huge current running through it. And I think that's pretty much it for that. The big thing that I know you guys want to see is these gnarly thermal burn pictures, right? So first degree, nobody cares about first degree. It's pretty much just superficial redness. Nobody's going to do anything about it. If anybody is calling you for a first degree burn, there's a serious problem, and I would recommend some education. Another thing to know about the first degree burns is that they don't count towards the total body surface area, and I'll show you a little bit more about like how to calculate it. But this doesn't count. If they come in and they have like second or third degree, then we'll count that. But first, we don't really care. So second degree, they've actually broken this down. So it used to be first, second, third, and fourth. Like that's what everybody knows, right? That's what everybody started to get comfortable with. And then there was like, actually, we're going to change it. So now it's like they go by superficial, which is first degree. Second degree has been split now to superpartial and partial full. Third degree is full, and then fourth degree is still fourth degree. I don't know. So I've seen in the burn bay that they still use them interchangeably. You just might hear different sayings. It's the same thing. Second degree, the thing that makes it different is that you're going to have blistering, you're going to have skin disruption, but sensation is intact. You can still have blanching and it can still look white. That doesn't automatically make it a third degree. If you have a white patch on the arm, if you press it and they're like, oh my gosh, that hurts, then we classify that as second. On the opposite, on a bit more escalated scale, you can have blanching, but now you've got sensation disruption, which means that it's affected the nerves, it's got to that layer, and we'll classify that as third degree or full thickness. You can have some scarring. This picture down here shows that first and second and third degree, it doesn't really matter about how much it actually covers. It can appear the same, it can be white. Again, the difference is like, do they have sensation or not? Has it affected nerves? Has it got that low? And then fourth degree, you'll never forget it if you see it. Like it's just obvious charring, like it's just not going to have a good outcome. This is how we classify. This is the scale that everybody's kind of taught, the Browder and Lund chart. You can memorize this. People also do the palm as well. The one thing that people have difficulty calculating is that the first thing is that they use their own hand. So it should be the patient's hand. So when you've got someone and you're like putting your own hand on it, it doesn't work that way. You've got to like look at the patient's hand. And the second thing is that people just use the palm because they call it the rule of palms, but it should be the entire palmar surface, so including the fingers as well. It's a little bit different for adults. Males are 0.8 for the entire hand, women are 0.7, but I mean, again, in the ED, they still do just 1%. Usually it's good for less than 15%, but people still do it. So this is a good one to know though. So if you see like a total arm or say a leg or and it's just a little bit, they'll be like, okay, well, we'll call that 7%, and they'll just kind of add it up. It's very rough. And the thing about this is not objective. It tries to make it objective, but I guarantee you, if you took like 10 physicians and said, calculate this total body surface area, I guarantee you that they're all going to be different. It's just the way it is. It's just an estimate. So you get a call, you're responding out, you're rescued to a fire, there's some people that need assistance, always ABCs. The first thing to think about is the airway. So there's some people that have obvious signs of inhalation injury. Some people can have like proteinaceous sputum, discolored, it can be like red, it can be yellow, gray, black. Do I need to intubate? So the indications that we use over at UAB is usually, obviously if they're unresponsive, I feel like that's a given. If you've got somebody that has deep facial burns, but they look pretty good, you could consider it, especially if you've seen like real bad charring, 4th degree around the mouth and the nose. They may look great now, but they won't be later, and then you're going to be upset that you missed your opportunity. And then obviously if you see somebody that has facial burns and they're in real bad respiratory compromise, so they're huffing and puffing and their O2 is like 88%, but they're still with it, I'd consider intubating those as well. If you can use an 8.0 or larger, and the reason is when they come to us and they end up in the ICU, they'll end up getting a bronchoscopy, and I put a picture of a healthy looking trachea up here in the corner. You can see somebody that came in with an inhalation injury, like after they got to the ICU, so probably like 2 or 3 hours after they got to UAB. And then the bottom picture is 18 hours later. So you can see what a difference it is in terms of airway. If you can't like get the tube in, you need to put a smaller one in, then obviously that is more important. But if you have a great view and you have the opportunity to get an 8.0 or bigger, that would be really helpful because the bronch can't fit through anything less than that. Another thing to think about is when you intubate someone, it's usually not a problem in the field unless you have long transports. The edema around the throat itself, around the mouth, it waxes and wanes a lot, so you can see like significant swelling, especially if it's a real bad inhalation injury. Just watch your tube length. If you like tubed and it's like 24 at the teeth, just check it again just to make sure it's not alternating too much, just because the edema can sometimes push and manipulate the ET tube. Here's some examples that would be a great view, right? If you intubated and all your airways were like that, you'd be like, man, who said that intubation was like tough? But then the problem is that you get these airways, especially this one up there from these inhalation injuries, and you're like, what the heck am I going to do with that? First of all, I'm not getting an 8.0 in that, right? I'd get you bougie for this. If you have a bougie available to you, they're fantastic for these difficult airways to just kind of get it through. Obviously, if you've got that one over there, you don't need a bougie for that. You can probably just slide in a fire hose to that. But that one you're definitely going to have issues with. So I just advocate for that. If you take a look and you're like, this just ain't happening, just do your bougie and get what you can in. If you have the option to do some humidified oxygen, that can help for these burn patients. I don't know if you have the option to hook it up to your ET tube, but even just a face mask, just having them breathe, just get your nebulizer, just put some saline in it without the albuterol and just let it run for a bit. And then the big thing is that remove the clothing, especially around the extremities. If you're seeing it tight, a lot of these patients with the swelling can cause like compartment syndrome, and you don't want it, make that worse by having tight clothing on. So just cut it down. We're going to do it as soon as they get to the ED anyway. We've been trying to be better about this because everybody really gets upset that we completely like cut off all their clothes, and they're like, that's my best jeans. So like in some patients, we've started to be a little bit like better, but burn patients, it's all coming off. The big thing for them is that they are going to need a lot of hydration, especially anything that has a burn of more than 20% total surface area. So I'd go ahead and get some good IVs in if you can. The larger the better, but again, do what you can. We use the Parkland formula. This doesn't really apply to you guys much because you're just going to be doing, you know, the initial fluid starting. But what we do is we take 4 cc's, times it by however much they burn, so like 40%, and then times it by their weight in kilos, and that's how much fluid they're going to need over a 24-hour period. And we split it in half, give the first half over the first 8 and then the rest over the 16. What we have over at UAB is we recommend just doing initial, anybody that you guesstimate is 20%. I mean, if you get 15% calculated and you're like, but they still look terrible, like no one's going to fault you for giving fluids. If you give 10 cc's per whatever you calculated, so say you did 30% like total body surface area, just give them like 300 cc's when, you know, you're getting them in. The larger folks, anybody that you know is above 80 kilos, give them 100 cc's for each additional 10 cc. So each additional 10 kilo weight. So if you've got a 100 kilo guy, he's going to get the initial amount for whatever his weight is up to 80. And then from the 80 to 90 and the 90 to 100, that would be 210. So you give them an additional 200 cc's. And that should be more than enough to give us like a good start on fluid resuscitation. And the big thing is that we want to use LR as well in our burn patients. That's our preferred fluid. Another thing that you have to worry about in these burn patients is anything circumferential. So anything that's circumferential around the extremities, we're likely going to admit. And the reason for that is that when that starts to swell, it can cause blood and nerve circulation to cut off, so they get a compartment syndrome. If it's bad enough, then we can do escharotomies, which is where we cut down the side, or we don't, the surgeons do. But they'll do it in the ED. They'll just get like an 11 blade and just kind of slice down if there's, you know, any kind of vascular compromise. And this isn't just for extremities. So we worry about, you know, loss of limb, but you can get it in the torso as well. The only difference is that if I get compartment syndrome in my arms and my legs, yeah, that leg's going to go. What if I get compartment syndrome in my torso? Right, what's going to happen there? It's not really a blood supply issue at that point. It's a respiratory issue, because the problem is that my chest can't expand. And even if you intubate someone and you're trying to bag them, if they have like a torso compartment syndrome, it's just not going to help. It's essentially just like a tension pneumothorax. You're just not going to be able to get what you need. So they'll do escharotomies on these patients as well. And we had a pretty bad one at Children's that came in as a transfer from down south, and they ended up having like over 100 escharotomies, like on the fingers and arms and on their torso. They'll do it on the neck as well, because if you think about circumferential burns around the neck, that can also be an issue. So anything circumferential can be a huge problem, and we usually admit those like 100% of the time, even if it's like a second degree. If it's bad enough, we'll admit it. So the take homes that I hope is helpful for you guys, and definitely helpful for us, is grab the chemical data for whatever they get like exposed to. In electrical burns, just grab a quick 12 lead, just check the intervals and just make sure it doesn't look really wacky. Intubate the really bad face burns, just because they're breathing now, they may not be breathing well later. Obviously, you know, I'm talking like 3rd and 4th degree severity with some of the pictures that we saw on there. Good IV access is going to be amazing. If you can't get it, then, you know, not a big deal. Just do the best you can, and we can get access in the ED. And then if you can start the fluids on these bad burn patients, anyone greater than 20% total body surface area, they're probably going to need some hydration. And that's it. So that's all I have. Hopefully that was helpful. Does anybody have any questions?
One thing that people are asking about is how important is maintenance of the patient's body temperature?
So one of the things we worry about in burn patients is obviously hypothermia. They lose the ability to regulate for themselves. We always keep our burn bay pretty warm, especially it's nice during winter, because like if you're freezing cold, you'll just like go and sit in the burn bay for a little bit. If you're out in the field, do your best to keep the patient warm. If you need to use warm blankets, I would err more on the side of keeping them hot than keeping them cool. I don't know how much of a difference it's going to be in the initial transport, but it's definitely one that, you know, we'll make sure their body temp comes up. There's no set number that we look for over in the ED. We're not like checking the patient's temperature regularly. But yeah, warmer rather than cooler would be preferential.
We've also got a participant making the point that thermal burns always look much worse the next day or later.
Yep.
And it's very easy to underestimate severity of burns right after they happen. Was that consistent with your experience?
100% yes. So usually 48 to 72 hours is probably the worst that they'll get, which is why we have a low threshold with these third and fourth degree burns. Anything, you know, greater than 15, 20% will get admitted. Just because you just don't know what's going to happen as far as like how far it's going to progress. And they really need a close eye on them. So yeah. The best it's going to look is probably when it initially happens, and then it just goes downhill. So
as far as initial bandaging for us, we've all been trained to use a dry, sterile burn sheet.
Yeah.
Is that pretty much what happens at the ER as well, or is there any kind of salves or irrigation or anything that y'all use different?
Yeah, so what we usually do for like the burns itself is the first thing we do is debride the area. Usually it's a pretty, it's sterile. It's like a flash for all the bacteria. It kind of kills it all off. So we end up debriding, which is just getting rid of all the charred tissue, all the dead tissue, anything that could potentially cause infection. If there's real bad like bullous blistering, we'll actually cut that and kind of clean it out, wash it off, rinse it. And then we use what's called a Mepilex dressing on most of our burns. If they become like more severe, full thickness, then they consider like adding a more silver-based dressing, but it can affect some wound healing. So they use it with caution. But Mepilex is usually our go-to. It's like a non-stick, kind of like a Teflon dressing that has chemicals in it to help with healing. So. I'd say any burn dressing, if you use dry or wet to dry, no one's going to fault you if somebody comes in with it. So,
do you ever see hyperkalemia or other derangements of electrolytes associated with burn injury? So
yeah, we do.
What's the mechanism there? What could cause that?
So the biggest thing is you end up getting a real bad metabolic acidosis just because your body is so ramped up, like you've just got a severe trauma. We see potassium, so the muscles can die even with electrical. It can happen with thermal. So anytime the muscle releases electrons, whether that be potassium chloride, you can have derangements from that. Potassium is the big one though, just because it has the ability to affect the heart. So we still tend to get EKGs on the thermal patients. It's not usually as emergent as we do with the electrical burns, but they'll still be getting constant BMPs to check, and make sure that they're not going into any real bad acidosis. They tend to get anybody that's greater than around 60% total body surface area has a real bad cardiac respiratory depression. They get really permeable, leaky vessels. And that in and of itself, you're not able to keep up with that demand. Secondary to, first of all, you've got vascular injury and now all your blood is your third spacing. And then the second thing is that if your cardiac function is depressed, you're not going to be able to keep up with the metabolic demands that the body is. So you end up kicking over into like a lactic anaerobic methods, and you tend to get lactic acidosis, and that doesn't help with your general metabolic acidosis. So there's a whole bunch of different organs that can be affected. So yeah.
So a lot of our audience today, Dr. Rose, are structural firefighters. So oftentimes we rescue people from enclosed spaces at a structure fire. Well, not often, it's actually pretty rare, but very few of them survive. So it's been speculated that a lot of that's due to cyanide poisoning, maybe other issues. So based on what you just said about the electrolyte derangements that can occur, so even a fire victim that looks like it's primarily burn or inhalation injury, cardiac monitoring still pretty important?
Yep. Yeah, 100%. So we always consider cyanide poisoning in the burn patients, and the usual treatment that we do is the 5 grams of the hydroxycobalamin. That's our first line treatment, and then we have second lines, but usually it's pretty available over at our ED. I don't know how it works at other facilities. And the mortality, there used to be it's called a Bork score, where they would calculate the estimated mortality from these burn patients, and it was pretty much your age plus whatever percent burn you were. That's your percent mortality. So anybody greater than 50, their mortality just skyrocketed, especially if you're getting more than 40% total body surface area. You're like fast approaching 90 to almost 100% mortality. So these patients get real sick real quick.
How long of a stay do most serious burn patients have in the burn center? I know we've had some patients over the years that seemed like they were there for over a year. Is that something that happens?
So I hate when burn patients come in, because you just know looking at them that it's going to just be awful for them. It's just a painful, miserable process. Everybody is different. If you've got airway involvement, then that complicates things a little bit more. If it's isolated and you know the percentage area, I think adding an inhalation injury added like 20 mortality points onto the Bork score. So everybody is different. Just depends on the severity of the burn, kind of if there's inhalation involvement. But yeah, people can be in there a long time and it can be pretty miserable. And sometimes if we have somebody, even if they've got no inhalation injury, if they have severe enough total body areas, we'll do like what do they call it, Ferg? Like a palliative intubation, or just kind of an intubation for comfort, because the amount of debridement they're going to have, it's not nice. So you wouldn't want to be awake for it, You can sedate them in the ED, which is sometimes what we'll do if the burn is real bad, but if it's that bad, people they'll intubate them just for comfort measures. So it's not fun, and especially in the kids as well. They're going to have to live with that for the rest of their life, and the road is just long and painful. So it's just the way it is.
Yeah, so you think about burn management, I always think about pain management as well. Textbooks say 3rd-degree burns don't really hurt, but nobody has just a 3rd-degree burn, right? It's always going to be kind of mixed up. So years ago, when I was doing EMS stuff, we would take somebody that used to go to the Mississippi Firefighter Memorial Burn Center up in Greenville. Before we landed there, we'd always empty the narcotic box out and give them the pain medicine. So, pain control is very important. There have been several cases that I've seen where the patient comes in, they're awake, they're alert, we know they have significant burns with a high rate of mortality, they're probably going to die. And I think it's reasonable to discuss that with the patient so they can make peace with whoever or whatever they need to make peace with. You don't look at somebody and say, dude, you're burned, you're going to die, right? But you be honest with these people, because once you start sedating and giving pain medicine, they won't be able to say their goodbyes and kind of close the loop with their family. So it's sad to say, but you got to be honest with these people and do that. And if they make the decision, yeah, I'm hurting too bad, I'm going to make peace, but I want my medicine, then we will sedate them, palliatively intubate them, pain control, things like that. Because burns are horrible. You guys know that. It's kind of like preaching to the choir with the fire departments. You're talking about chemical stuff with the hydroxycobalamin. We used to have a cyano kit where you would break the capsule, then sniff the capsule, then do this and convert it. There's like this big pathway to kind of convert cyanide so people don't die from that. The hydroxycobalamin is pretty easy now. It's fairly cheap. There's limited risk. You guys are firefighters. What things can you burn and make cyanide? What things in houses? Y'all got to know this stuff. You're like plastics, carpets, those older places, like the old nasty couch. So lots of things have cyanide. So if you got somebody in a house fire, that you get in there, the altered, the unresponsive, they are coding on you, it's very reasonable on our side to give the hydroxycobalamin. There's limited risk, potential benefit. It's not an expensive drug. It's easy to do. So that's a reasonable thing. You think about electrolyte derangements. I've seen burn patients that have come in a couple hours out from a burn, and you start watching their EKG. We made the decision they're not going to survive. They want palliative care only. And then you start watching the cardiac monitor. You can tell they're going hyperkalemic because you think about all the cells that are burst open from the burn. That potassium is really big inside the cells. So when the cells burst, it gets into the bloodstream, they get hyperkalemic, and you'll see the EKG change, and it's pretty dramatic. So what do you see with hyperkalemic changes on the EKG?
Peak T wave.
So textbook says peak T waves, you see that first. Peak T waves really won't hurt you, but they make you think, oh crap, the K's getting high, we need to check it, right? The next thing you see is a wide QRS. So they go from a sinus tach, because their body's stressed, and that QRS gets real wide, pyramidal goes away, and it almost turns into a sine wave. So burns are very sad to manage. I agree. What other questions you got within reason, guys?
Hey, Doc, we got one from the internet. It's a little bit off topic, but what was the national certification that you mentioned? And kind of a piggyback to that, is there any physician specialty or physician specialty certification for burn care?
So I feel sure there is. The American College of Surgeons has a burn specialty. And we have one burn specialist at UAB, is that correct? Is that the guy?
Yeah.
Yeah, I don't remember his name. So there is a physician specialty for burn management. Those surgeons basically go through med school, they go through residency. Surgical residency was 5 years. And they do another 2 or 3 years of critical care. And then most of them do another 2 years of burn management. So you're talking about a guy who's got long training before they're overseeing these burn drugs because it's very complicated.
At the elevator, PD has been notified.
Was that the question?
Yeah, what was the certification that you mentioned earlier?
Oh, for EMS? Yeah, so the American Board of Emergency Medicine, the board that says you have passed your ER, it's like the National Registry for ER docs, has a new subspecialty. It's called the EMS subspecialty. Pretty high tech, right? It's EMS, yay. But in 2013, they approved the first test for that. There was a 5-year period where you had a grandfather clause. So if you had a doctor that had been working in EMS for a while, he could take the test and get board certified in that and get the patch. But now that pathway is closed, they have to do an extra year of training. So med school is 4 years, residency is 3 to 4 years, and now you got to do a 1 or 2 year fellowship after that to be trained in EMS. But the goal of this is to get more physicians involved, to get docs out in the field. If I was king for the day, I'd have 2 or 3 physicians out, 24 hours a day in the greater Birmingham region. Okay, maybe even more during peak hours to kind of help with you guys for online med control. If somebody's in trap, help with the RSI, things like that. And then for just educational purposes. We're not anywhere close to that yet. But come July 1st, we'll have 2 more physicians doing it. So we're getting there. Cool. I'm going to try to, we got a few minutes. I'm going to try to see if I get that burn video to load real quick. Chief, if that's okay.
Yeah,
What other
excellent.
questions y'all got?
Yeah, bear with us just a minute as we swap the technology over.
Not a question that a pediatric said at Children's came south. Probably knew exactly which one it was. We had a house fire in Montgomery, overnight daycare center, 12 critical burns. Like 8 of them sent out by helicopter to Children's, and Georgia and Tennessee.
This was a girl. She was with her granddad, and I guess they were on opposite ends of the house, and there was a propane tank that was next to the house that exploded. I don't know what caused the initial explosion, and that side of the house caught fire where she was. So granddad essentially got out fine, but the girl, I think she was 5 or 6. And the thing that was crazy is she came in and she was a small black girl, but her skin was so charred. I thought it was a white kid at first because you couldn't see. She was completely bandaged all up. You just see little areas of her skin. She was just, it was awful. It was real bad. She ended up going to the OR probably 5 or 6 times within that first 24 to 48 hours. She got like an immense amount of fluids just because they really regulate, every hour they'll look at how many cc's of urine she makes. And keep replenishing it. They're really on top of it. The burn folks over at UAB, she ended up getting actually transferred out to Texas because it was just that bad that even the children's folks couldn't manage it.
Yeah, so high risk, one, think loss of skin, so you got high risk of infections long term, there's thermoregulation, you got cellular breakdown, so you got all these electrolyte changes, you get volume issues. If you don't manage the volume well, the kidneys start dying off. When the kidneys die off, everything else starts dying, so it's a long road at best for these people. It really is. This is a burn several years ago. But this is a video scope. If y'all need to move closer, you can, and we'll turn the rest of the lights off with the live stream for the folks in the room. But obviously, this is carbonaceous sputum. All right, so that's a no-brainer. You can recognize that. This is the airway. You can tell. Look at all that soft tissue. So all your natural landmarks that you usually look for are about gone. You can see the epiglottis there, but that thing is still swollen. So these folks need early aggressive airway management to get them intubated. And this was a downtown Birmingham fire they brought in pretty quickly. So it doesn't take long to get this done. So here you can tell we're just basically looking for bubbles. So this is someone that was sedated, we paralyzed, and we're looking. And even with the video scope, which I'm a big proponent of these things. I think it makes it much easier. It's like cheating, but when the anatomy is jacked up and swollen, it's still a tough airway damage. So it takes a long time. See, that's the cords there. It really doesn't look right, does it? Now here's the comedy. It's not comedy, I should say. I think they're back. The person intubated forgot to deflate the cuff. That makes it a little bit harder to get the ET tube in. The cuff is not deflated. So this is a great learning one. It shows you what the airway looks like in a significant burn, so that if someone comes into the ER and I'm taking care of them, and I even have a hint of an inhalation injury, they get sedated and intubated right off the bat. And if a couple hours later they're doing fine, I extubate them. And if not, they need to be intubated anyway, right? So I'd rather intubate them early and have an easy airway than wait till we get like this.
So, hey, Doc, one thing this video doesn't show that we see sometimes from structure fire victims is debris in the airway.
Yeah.
You got it.
Yeah, chunks, soot,
Yeah.
ash, right. So bougie is nice here. We're able to get that in. So now you can breathe a little bit easier. Your airway will be secure. And now they realize, oh, my cuff is up. I deflate the cuff and the patient gets intubated. Well, yes, remember, if it doesn't fit, don't force it. Deflate the cuff and things get better. Right. But these are jacked up airways to manage. So obviously you guys aren't going to stay on scene long anyway. The other thing I would mention is that when you think about burn injuries, things that have bit me in the past, is you forget their burn, inhalation injury, you manage the airway, you think about your fluid resuscitation, I'm giving pain management, I'm thinking everything's going great, I'm cool, I'm calling the burn center, and then, oh crap, by the way, he also jumped out of the second story window because he was on fire to get out of the house fire, right? So like, oh crap, I forgot about thinking about other injuries, trauma, right? So you still got to think about other life threats. Did you break a femur? Is it deformed? Is there a head injury? Is there a chest injury? So you can still do your primary exam with these burn folks in a matter of minutes, okay? You look at them, you know they're gonna need rapid transport, you know they need airway management, you're working on that, somebody's running their hands down, checking for crepitus, squeezing the chest, if it's stable, looking for crooked extremities. If you can't get IV access to a burn patient real quick, what can you do? Drill them, yeah. Everybody's having drills these days. You don't have the drill, the easy, there's a new one out there that replaced the big. I hate the big. Anybody carrying the big? Good, good, good. The Neo, that's the name of it. Neo works too, but drill these people. State says that we can do IOs in the distal, in the proximal tibia. We can also do the humerus, okay? If the tibia is broke, you can't use it. If the arm is broke, you can't use it, right? You can do other places. You can do a distal femur. It's not approved by the protocol, but if I got a guy that jumped out of a second-story window, he's got broken arms, he's burned pretty bad, and busted tibias. If I think the femur's intact, I call him in control. Hey, doc, I got this 40-year-old male. 80% third-degree burns, needs an airway, he's got busted tibias and humerus, I need to drill his femur. You can do that as well. So think about things that can help you out. If the device, if the skill is in your scope of practice, if the medicine is in your scope of practice, you can use it. Now, you may have to call med control for that, but you can. Years ago, before we had magnesium switched over to respiratory, magnesium was only used for torsades, right? So what we do is tell people, hey, you've got somebody having a bad asthma attack, call med control, ask them to give 2 grams of mag, because magnesium is great for bronchial constriction. All right, we finally moved along, put in the protocols. Same thing, like the TXA, you can use it for other things, call it. Right.
Hey, Doc.
Yes,
so we do have a good question here. So on an airway like the one that you just showed on that video,
Yes.
would the supraglottic airway be useless and just bag, or would you still try to use the supraglottic airway? Because obviously, even an iGel probably wouldn't seal to that.
Yeah, I think with an airway like that, they need intubations. They're probably, I can't say the hosed. I would, if you can only do a supraglottic, if you're an EMT or an advanced and you can't intubate, yeah, if they need an airway, I'd slide that iGel in there, that king in there. If it works, great. If not, put OPA in a back valve mask. What they need is intubation. So if you're on scene with ALS and a medic and the guy's got a gag, you're kind of toast. I can't say call in and get orders for ketamine and Versant because that would get us all in trouble to do that. So I can't say that. That's a reasonable option in some situations, but you probably won't get approval in this area for that. If you're an ALS provider that has the expanded scope and you can RSI this guy, that's somebody that I look at him, he's jacked up, he's burning, none needs an airway. My partner's doing the primary assessment, they're drilling him. I'm moving toward the head. Somebody's throwing off the drugs. He gets his ketamine, his paralytic. We intubate him right there. Shouldn't take more than 2 or 3 minutes, and you pack up and you go. He needs intubation right now, but you can't put him down with sedation. You're kind of in a bad spot. What else you got, Chief?
That's all the questions. Hey, thanks, Dr. Ferguson. Thanks, Dr. Rose. Great lectures today. Thanks for Alabaster Fire for hosting us and Alabama Fire College for sponsoring us. And we'll see everybody next time. Next event, Dr. Ferguson, is December 9th.
December 9th, we, Anderson, I'll post on the RIMS webpage. I'll get that posted this afternoon, hopefully. And on Facebook, the location will be at Station 6. Is that what it is?
Yeah, it's the Anniston Regional Training Center, which is Anniston Station 6.
Right.
And then starting in January, we're kind of going back to a regular schedule. We'll be at Centerpoint Fire on the 2nd Wednesday of each month, and the 4th Wednesday will be somewhere else in the state.
Yeah.
Already had a couple people contact us today during class, want to host, so we look forward to making it out to all those locations. Everybody, please remember to fill out an attendance form. The link is in the Q&A if you're online. Even if you don't need the credit, it helps us figure out who all we're reaching. The password for today's lecture is BLAZE, B-L-A-Z-E, all lowercase. Thanks again, everybody, for listening in. We'll see you next time.
Thank you.